Hello everyone, Namaskara. I'm Dr. Priyanka Singh. I welcome you all on behalf of IDA Bangalore chapter. Abdominal cocoon is a rare condition characterized by a thick fibrotic membrane that partially or totally encases the small bowel, leading to recurrent intestinal obstructions. Patients suffering from abdominal cocoon often presents with a severe malnutrition, muscle wasting, and micronutrient deficiency. Today, we are going to learn about the abdominal cocoon and its nutritional management therapy with the help of a case study. We have Dr. Rajesh and Dr. Shobha to put light on the topic. I request Ms. Daphne Balan, Chief Dietitian of Baptist Hospital. Ma'am is, can I have ma'am? Ma'am is a registered dietitian. She's Joint Secretary of Indian Dietetic Association Bangalore chapter, Registered Dietitian Board Representative, Indian Dietetic Association Bangalore chapter. Over to you, ma'am.
Please forgive me. Welcome again. And this is an interesting session on a very rare but acute topic. So, my first introduction is of Dr. Rajesh, who is an MD, IDCCM Fellowship in Pain Medicine. Sir is consultant and founder of Tatva Jyana Healthcare Skill Academy. He is passionately committed to transforming healthcare education through practical, skill driven training. He's also a teacher for the IDCCM course, which he completed, conducted webinars of medical law and ethics, and is faculty for communication workshops conducted by national conferences. We welcome you, Doctor, and this time is yours to enlighten us on this very special topic.
Thank you, ma'am. Thanks a lot. Hope I'm audible to everyone. Is it clear? Hello? Hello?
Yes, you're audible and visible both, doctor. Very much.
Okay, yeah. There is a little lag, I believe. Okay, anyway, I welcome you all. So today we are going to discuss regarding the abdominal cocoon syndrome. Uh, it's one of the rare cases not commonly seen. Okay. Is my slide visible? Okay. So we'll talk about the abdominal cocoon syndrome today. Let me keep this an interactive session, so I want everybody's participation and actively involvement in discussing this case. Let's have a case here. A 58 years old male patient admitted at Maharaja Chiang Mai Hospital who exhibited an escalating left lower quadrant abdominal pain which was persisting for 8 hours. For 2 years, he had intermittent experienced chronic abdominal pain. Though the symptoms spontaneously resolved, abdominal pain was not associated with either nausea or vomiting. With this, on further evaluating or asking for the history of presenting illness, he had a medical history of non-valvular atrial fibrillation, right, which was managed by taking 2 mg of warfarin. So, further examination revealed pronounced tenderness and guarding was observed in the left lower quadrant and had a palpable mass of around 5 to 8 centimeters, which has a firm in consistency. So we did get lab investigations which showed elevated leukocyte counts, that is WBC, which was around 11,000, and C-reactive protein was 175, and rest all the parameters were within normal limit. Right. So this is the radio imaging, which has a X-ray, which looks almost similar. It's normal. It doesn't show significant abnormality. You can see here there is no gas-filled or air-filled abdomen or bowels. Again, the same X-ray in the different view. It doesn't have any significant abnormalities. Then we have to get a CT done. So can you identify the problematic in the CT? Am I audible?
Yes, doctor, you are very much audible. Yes.
Yeah. Audience, I have option to
Uh,
talk now.
Doctor,
Those,
this will be a closed group. Only we are there. Audience
okay.
can only post their questions. Yeah.
Okay, okay, fine. Yeah. So you can see the CT film here.
Yes, yes, we
Uh,
can.
you can see this thin lining, right? Fibrotic. This is the encapsulating mesentery over the intestines, right? So this is the only finding in the CT abdomen, which will tell you or which will guide you that it could be a abdominal cocoon syndrome. And in this CT image, there is no dilatation of the bowel or even obstruction. So with this image, they had a clue that it could be a abdominal cocoon syndrome. So what is the first line of treatment they did? They did was it was a conservative management, and following which the patient exhibited fever with increased abdominal pain. On further physical examination, he had a tenderness around the mass, guarding specifically in the right lower quadrant area as well. So the exploratory laparotomy was performed, and you could see the findings of exploratory laparotomy that there was a dense fibrotic tissue enveloping the third part of the duodenum up to the upper rectum. It was like a cocoon appearing substance, and subsequent resection of this fibrotic tissue revealed approximately 20 centimeter of the medial ischemia, contributed to the wrapping of fibrotic tissue around the mesentery. So this is the image intraoperative. The white portion is the fibrotic portion which was covering the intestine, and in the B, you can see the removal of this fibrotic substance. The intestines are well exposed. At this part, when they removed this part of the fibrotic band, you can see the ischemic gut, right? So this was the finding intraoperatively. So when they saw this findings intraoperatively, the resection of the affected segment of the small bowel with end-to-end anastomosis was done. So coming to the outcomes and the follow-up, the patient was discharged on seventh day post-operatively, and there are no post-operative complications. So after 2 week of follow-up, the blood chemistry had returned back to normal. The cultures was negative for virus, bacteria, or mycobacteria. The resected dense colon, which was sent for the histopathology, revealed fibrous formation, and there was no signs of malignancy. The entire white color tissue was fibrotic. So, with this case study, we can have all other symptoms from the same patient. So, we'll just look into the signs and symptoms. There can be even loss of appetite. There can be constipation because the fibrotic band will be constricting the bowel. So, the constipation, weight loss because of the absorption problems or absorption issues. Some patient may even present with a palpable abdominal mass, like in our case. He was not presented with a palpable abdominal mass, but on examination we found a abdominal mass. There could be even ascites also because there will be a inflammatory condition, and in some similar case it might resolve on its own because our patient which we are discussing, the case was the symptoms were being resolved on and off, and it's the similar symptoms has been persisting for few years. And this disease is very slow to progress, and 29% of the patient require emergency surgery at presentation. So emergency surgery at presentation means the patient usually come with having a complications. So what are the complications we are talking in case of the abdominal cocoon syndrome? There could be intestinal obstruction, as I said, because of the fibrosis of the tissue. They constrict the bowel, causing obstruction. There could be ischemia because the bowel is constricted, the blood supply will be hampered. There is a high possibility of ischemia. In this case, we have also seen there is a ischemic gut and bowel perforation because once the ischemic part set in, there will be high chances of perforation of the bowel, and some patients might remain asymptomatic for quite a longer period of time. So, the therapeutic part, there are two types. One is the conservative and pharmacological, other is the interventional. So, initially, when a patient comes with such symptoms, the first and foremost priority is given for the conservative or pharmacological. So, what are the conservative management? The patient with mild symptoms should initially receive non-surgical management like pain relief and and pain relief and anti-inflammatory medications. The key component of conservative management include the bowel rest, nasogastric decompression, and very well nutritional support. Could be either enteral or parenteral. So, nutritional support. So the correction of the nutritional deficiency is very much essential, and the benefits includes the better response to the conservative therapy. It reduces the risk of surgical complications like infections and fistula formations. So coming to the pharmacological treatment, as we know, the abdominal cocoon syndrome can be because of the inflammation. So one thing is to reduce the inflammation. So what are the medication we use for reducing the inflammation is tamoxifen, steroids, which again is the anti-inflammatory, colchicine, and azathioprine. So the role of tamoxifen and steroids. So this combination therapy may help prevent and treatment of SCP. SCP is sclerosing encapsulating peritonitis. In the other word, it is called as abdominal cocoon syndrome. And the corticosteroids likely to act through anti-inflammatory effects, as I previously mentioned, and immunosuppressive properties as well. So early intervention in special scenarios. So early use of tamoxifen can be beneficial in initial stage, particularly useful in patients with long-term peritoneal dialysis, with a ultrafiltration failure, high transport status, and absence of typical imaging findings. So coming to surgical part, is advised only when the conservative or the medical management fails. Should ideally be performed in a specialized center due to technical difficulty and high risk. So first is the conventional management, that is non-intervention, and if non-intervention fails, then we move into the surgical part. Or else the patient comes with a complications, right? Like a perforation or peritonitis or severe intestinal obstruction. Only those are the conditions where the surgical intervention is preferred. Now, coming to the types of surgical procedures. The procedures may include enterolysis, that is removal of the fibrous membrane and the adhesions, limited adhesinolysis for the specific complications, the injector dye which reduces the adhesions to the bowel, resection of the ischemia or the perforated bowel segment. So these are the different types of surgical procedures which are performed. So the patient with a severe intestinal obstruction and intraoperative diagnosis of SCP should undergo laparotomy or laparoscopy. The moment you see there is a abdominal cocoon syndrome or SCP, laparotomy and removal of the adhesions should be done. The standard approach is complete removal of membrane with adhesiolysis. So in case of bowel injury, again the resection and anastomosis is preferred to prevent further complications. So, what are the factors which are affecting surgical outcomes? Like long-term peritoneal dialysis, if the patient is been on peritoneal dialysis for quite a long time, that is a predominant factor which is going to affect the surgical outcomes. So, because the peritoneal dialysis is the one where the momentum is the main driving force for removal of the waste product, and that momentum has been used for quite some times, such as more than 10 years for removal of the waste products. In such scenarios, removal of the adhesion or adhesinolysis in abdominal cocoon syndrome becomes challenging, right? And even when it is done, the complications are quite high. So this is the most important factor which is affecting the surgical outcome. So advanced peritoneal damage may lead to poor separation between the membrane and the bowel, increased risk of intestinal perforation during surgery. That is because of the addition of the membrane to the bowel. So peritoneal calcification further raises the perforation risk. So coming to the recurrence and prevention, so the complete removal of the membrane has a low recurrence rate. Use of anti-adhesive agent may reduce the post-operative adhesions, but the benefit of this is uncertain. Special consideration in secondary SCP, that is sclerosing encapsulating peritonitis, is that treating the underlying causes very much essential. In idiopathic, the diagnosis and treatment rely on the surgical findings and histopathological examinations. So coming to the advanced management, so intestinal rehabilitation program is required. Intestinal transplant in the severe cases is usually warranted. So coming to conclusion aspect, so abdominal cocoon syndrome is an inflammatory condition involving a thick fibrocollagenous membrane surrounding the small intestine. It represents the rare cause of small bowel obstruction, which was classified into idiopathic and secondary. Idiopathic, as the name suggests, it doesn't have any primary cause. Secondary, the cause could be something else which is affecting the abdomen. Definitive diagnosis, the gold standard is laparoscopy or laparotomy. CT scan is increasingly valuable for preoperative identifications. Surgical intervention is the most effective treatment when conservative therapy fails in severe presenting of SCP. So, any questions or any doubt?
We will take the questions at the end of the session once the case study
Okay.
of Dr. Shobha is finished. We have quite a
Yeah.
few questions. We'll take at the end of that session.
ठीक है.
Ma'am, do you want to take the questions for Dr. Rajesh now? Ma'am, you're on mute. Unmute yourself.
Yeah, shall we finish up?
We can. We
Yeah,
We
we'll
have
do
time.
that. Thank you.
Dr. Rajesh will take the questions now only. Yeah.
Yeah, sure.
Yeah.
No problem.
Yeah.
But thank you, doctor, for that educative, enlightening session. So this questions will be screened. This was a doubt. What is your biggest nutritional challenge as a doctor?
Okay. So the biggest nutritional challenge, especially in this case, would be maintaining the deficiency which has been caused for quite long. If the person is coming and having this abdominal cocoon syndrome for over a period of time, because this condition might resolve by itself and not get addressed quite often, so there will be a nutritional deficiency, and getting back the nutritional deficiency to normal is becoming a bigger challenge because first thing, until unless we address the whatever the pathological, the abdominal cocoon or the fibrotic portion is removed, how much
Yeah.
ever we give, that's not going to absorb. First thing. So second thing is that even if we give the amount what is already been used up, or there's a deficiency which has to be replenished first, and then whatever the blood values will come back to the normal status. So
Any specific deficiency that you see?
Uh, in the specific deficiency, what we usually see in such patients is the trace elements and electrolyte imbalance, which becomes really difficult to handle because of the absorption pathology which we see in these patients.
Okay. B12 could also be there. Iron can,
Yes.
no? Yeah. Okay. Doctor, when would you recommend surgery? Is that an
As I
inevitable choice, or do you postpone for
no,
some time?
No, that depends upon the patient condition. If the patient has come in the emergency department with severe abdominal pain and it suggests a peritonitis or a perforation, the emergency surgery is warranted. But if the patient is kind of a stable and the conservative managing on with the conservative management, his condition starts improving. That is when we are going to wait for some time and then later think about the surgical part.
Okay.
Basically, the
Okay.
condition of the patient depends on the surgical.
Yeah. So I did see a section where you said conservative management, but other than medication, what else would you all do?
So, other than the medication, the supportive care is that we need to give the rest for the bowel, and meanwhile, you need to, if the patient is malnourished, you should add some parenteral nutrition to build his health and the condition of the patient. So that's the
Yeah.
only thing other than the medications is
Sure.
advised at that point in time.
So that brings me to my next question. When would you refer to a dietitian?
So once the main pathological issue is sorted, like if the patient has to undergo surgery, once the surgery is done and the obstruction part or the fibrotic band is removed, that is the time when we refer the patient for the dietitian for further management, because until and unless we address the emergency thing, whatever we give as a dietetic part, it's not going to help either enteral or parenteral.
Okay. Yeah. So someone on the group is asking, on an average, how long does it take for the fibroid to grow in such cases?
Uh, it usually ongoing and slow process, as we previously discussed. There's no fixed time, like
Yeah.
how I mean,
I think she's
average of
talking about the membrane, not the fibroid as such. No, the membrane she's talking.
yeah, even the membrane, it's going to take depending upon the patient condition. It might have started in the early stage and it will take years together to
Oh,
manifest,
yes.
or in between. Yeah, in between patient may coming with similar complaints like mild complaints on and off. It might subside by itself or sometimes on medication, so the patient usually never come to the hospital for complete evaluation. So
Okay.
exactly the duration, you can't say how long it's going to take to develop the entire fibrotic, but the patient coming with the fibrotic will be having a quite long standing.
Okay. Okay. So someone else is asking, what are the secondary causes of
Yeah,
this syndrome?
yeah. So secondary causes is basically because of the inflammation of the omentum, right? It could be either the peritoneal dialysis, it could be frequent peritonitis, right? And it could be because of even intra-abdominal infections like appendicitis causing inflammation of the omentum, which leads to thickening of the omentum because of the inflammation. If that inflammation keeps on for a longer time, then there is a high possibility that those inflamed omentum becomes fibrotic, right?
Oh, okay.
So these are the causes which leads to the fibrosis of the omentum, further causing the cocoon syndrome.
Okay. Okay. So what exactly, how does this start, doctor? The membrane
So
starting
basically,
to
what
grow?
happens? What happens is the omentum, which will be covering the intestine, right? Any insult or any inflammation for the omentum, it slowly becomes inflamed because of the infection, and the inflammatory process involves fibrous band and other neutrophils, everything setting in inside the omentum. And when the healing part comes, it don't heal appropriately. When I say appropriately, means it doesn't come back to the normal stages. Sometimes such inflammation will change into the fibrotic bands. This is a process of healing anywhere in the body. For some
Okay.
instance, or sometimes for some patients or some person, it will be entire fibrosis, and it won't go back to the normal scenario. Especially, I can give an example of a peritoneal dialysis. That's why they have mentioned frequently a patient on a peritoneal dialysis for a quite long time. Why peritoneal dialysis is being stressed is because in peritoneal dialysis, the omentum is only one which acts as a membrane for transfer of waste material from the
Yes.
body to the peritoneum. And in the
Yes.
peritoneum, the peritoneal dialysis fluid and it has been absorbed out. In during that phase, the omentum becomes thickened and fibrotic if you keep on using the peritoneal dialysis for quite long time. That is one of the cause for the abdominal cocoon syndrome.
Okay. Yeah. Does age play a
Age,
factor in this?
yes, age is a risk factor. Usually, young to adolescent, somewhere
Yeah,
around
it was the
8 years to
premenstrual females.
yeah,
Yeah.
premenopal phase is more higher chance. And one of the cause, not 100% sure of that. I mean, the literature is not very strong, but even premenopausal stages is highly associated with abdominal cocoon syndrome.
Okay. Okay. Yeah, this was very interesting, and like I said in the beginning, it's very rare. Yet
Yeah,
it
it's a
has
rare
such a high
syndrome.
impact.
Yeah.
I think we may even get few questions after the dietitian session, so please stay back,
Sure,
doctor,
sure.
so that we
Sure,
can
sure,
have some
sure.
interactive questions. Yeah.
Yeah.
Definitely, definitely, ma'am.
Thank you, doctor.
Thank you, ma'am. Thanks.
We'll take this question afterwards.
Ah, yeah, yeah.
Shall we go on to Dr. Shobha? Yeah.
Yes.
So let me introduce to you Dr. Shobha. Dr. Shobha is a PhD in clinical and nutritional dietetics. She is the manager at Cloudnine Hospitals in the nutrition and dietetics department. She has extensive experience of over 25 years in nutrition, parental, enteral, and a lot of other topics that she has mentioned. And as you see, Doctor is well qualified to address this topic for us. So over to you, Dr. Shobha.
Thank you, Daphne ma'am. And I thank IDA as well as Dr. Priyanka and Dr. Daphne ma'am and others for giving me this opportunity. And I'll go ahead with the presentation. Yeah. Uh, yes. Hope the screen is visible and I'm audible.
Uh, you're audible, but we
You're
can't see
audible.
the screen.
I'm just checking for the screen once. Minute.
Screen is visible, right? Okay.
Not yet. I'm just checking. Just a second. Huh?
By the time, sure.
Dr. Shobha, please retry once.
Okay. I think it's visible now.
Yeah, it's
Yeah,
visible.
now we can see.
Okay, fine. I just presented. Yes, it's visible, clear. Am I audible?
Yes, very much audible.
Hope I'm audible. Thank you.
Yes, very
Thank you.
much
I'll not
visible
go
and
much into the detail because Dr. Rajesh has already discussed. Yes, thank you. I'll not go much into the details because Dr. Rajesh has already discussed about the case view and other things. I'll go directly into the nutrition in relation to the time also. So, as a clinical dietitian, most of us usually start with the anthropometrics, but from our side, as a critical care dietitian, practicing over so many years, I would always look at the case and then the nutrition related parameters which I take into consideration before getting into the diet or nutrition part of it. So when I got this case, I got to take nutrition related parameters with the patient, how the nutrition has been impacted over the years, and how have the parameters which I considered was the parameters which I considered was the pain in abdomen, because most of us say, like when you have even a common stomach pain or abdominal pain, the first thing we do is we don't take anything majorly, we don't consume any food, or we change the consistency, texture, or the form of the food, or we limit the food, or we change the consistency, texture, or the form of the food, or the food ingredients also would be changed. So this patient who came to us had a lot of complaints about frequent abdominal pain, and he had it on a longer hours for almost like 8 hours whenever he would experience the pain. Though he had no nausea or vomiting, but still when he presented to the ER, he presented with fever. That was one additional thing. So the pain was one thing which alerted me, like you would be either the change in the texture or the quality of the food, or the change in the quality of the food. quality of the diet or the food ingredients would have been changed. And if it was 8 hours of pain during daytimes, of course, the 8 hours feeding hours would have been reduced to 6 hours during this time. So similarly, though he had no surgical history,
Excuse me, Dr.
and he was
Shobha.
on warfarin. So that K and vitamin
Dr.
also
Shobha.
showed ascites tubes, and he had affecting also
Dr. Shobha.
tubes also was. So this thickening the digestion, the nutrients which are in the small bowel as well as small bowel nutrients absorb would be affected. So the nutrition absorption would be affected. So so explore
Dr. Shobha,
these.
d-
I think her line is lagging.
huh, huh. Somebody else. Your voice is breaking. I'll call her.
Yeah. Dr. Shobha, if you can be little louder also, please.
Your voice is little lagging. Looks like a network issue, but
Okay,
just be
fine,
little
sure.
louder so people are missing out a little bit. Yeah.
Okay, fine, sure. I'll be a bit louder.
Kindly resume the slides, please.
Yeah. Am I audible now? Clear?
Yes, yes, much better, much better. Yeah.
Okay, thank you. So what I was mentioning was like the nutrition related parameters which we consider, which I considered during the assessment of this patient was, one was the abdomen pain, second was the surgical history, though there was no surgical history of this patient, but patient had some medical history with related to cardiac, and he was on warfarin. So relating the nutrition parameters and nutrition was very important in this case, and the clinical condition to the nutrition also was very important. So I was taking everything which was happening with the patient related to the signs, symptoms, or the CT scan also, and the pathological as well as surgical intervention which was planned for the patient. So taking those things into consideration, taking all these parameters into consideration, and as nutrition assessment parameters. So surgically post resection, it was almost like 20% of the mid-ileal is for to remove the fibrotic tissue, 20 centimeter of the mid-ileal ischemia. So there was a resection done, and they had done a wrapping of fibrotic tissue around this fibrotic tissue was wrapped around the mesentery, so they just removed that. And appendectomy surgery was also performed to avoid entering into a hostile abdomen in the future as a prophylactic part of it. So nutritionally, what parameters I took was the usual anthropometry. He had around 170 centimeters and 56 kgs was his current weight, but usual weight was 72 kgs. So, taking his weight loss history, I understood that around 16 kgs over a time in the last 2 years he has lost, because he had these symptoms in the last 2 years. So, last 3 months, he had lost more than 9 kilos as documented. And biochemically, what we noticed was micronutrient deficiencies, like Rajesh sir mentioned. So, calcium, vitamin D, B12, folate, iron, and other micronutrient deficiencies was evident on this patient. And total serum proteins as well as albumin also was reduced. There was mild ascites also present in the abdominal cavity. Nutritional in this patient was a non-vegetarian, but he changed to vegetarian over the last 7 months. And 3 to 4 meals, from 3 to 4 meals, he shifted to 5 to 6 small meals a day. From normal consistency, he shifted to liquids and blenderized feeds over the time. So as tolerated, he was eating. He was There was no fixed timings or fixed meal pattern. He was eating as per his comfort and convenience in relation to the pain he was having. So whenever he had very bad pain and it was not resolving for him after medications, he used to avoid eating during those times. And slowly the whole meal was shifted only to rice, few vegetables mashed, thin dals and curds, and there was no oil spice. Majorly he was surviving on curd rice and milk and buttermilk. So, nutritionally, when we diagnose taking all these parameters, the medical, surgical, as well as the patient history, there was a severe weight loss due to reduced intake, and he was taking approximately somewhere between 600 to 900. This was dependent on the days of pains, or if he had some constipation issues, or if he was feeling uncomfortable eating anything, he used to skip his meals on those days, and he used to just take sips of water. So the intake was somewhere between 600 to 900 calories and 20 to 25 grams of protein with less than around 1.2 liters of fluids per day. So the reduced intake of vegetables, fruits due to restriction of vitamin K also we noted in this case because of warfarin, and abdomen discomfort and long hours of pain and presence of mild ascites. He had totally reduced fruits and vegetables intake, and neither sprouts nor pulses he was taking except tur dals. So reduced digestion and absorption of nutrient also was one of the issues relating to intestinal involvement, and surgical and intestinal resections were one of the concerns for us. So whether to start with oral or enteral feeding, and oral and enteral was ruled out for a period of 2 to 3 weeks. So nutritionally we worked up and parental lines were secured. Venous we had it for the first 2 3 weeks, and duration we wanted to know how long we are supposed to feed. None of us were sure, so we wanted to see how we would transit to the enteral diet and how quick the surgical wound would recover, and the surgical resection or the insert which have been done during the surgery, the recovery time required for that, because he underwent appendectomy also. We wanted to work on the stool formation also, and duration, feed adequacy, tolerance, all this was the concerns with us. And duration of total parental or partial parental and refeeding risks, plus enteral
We are losing you, Dr. Shobha.
Dr.
Sound
Shobha,
has
your
dropped.
voice is breaking again. Dr. Shobha, your voice is breaking again. Dr. Shobha, can you hear me?
Drug compatibility
I think her network is
with
gone.
regard to
Yeah.
parental and enteral
Dr. Shobha,
nutrition
kindly,
support also.
yeah, yeah, your voice is little feeble.
Hello.
Yeah, yeah, Dr. Shobha,
Kind
you're
of.
in between, your voice was very feeble. I think it's coming out now. Kindly continue.
Continue, doctor.
I think network is bad for her.
Even her video is frozen now.
Yeah, yeah, yeah. I was just trying to just Apologies, viewers. We'll soon be resuming. I think there's some connectivity issues. She's rejoining. Please bear with us. Don't go. It's quite interesting. I hope that we get a better network this time.
Sorry, some break.
No worries, no worries. It happens. It's okay. Please resume back. We lost you in
Yes.
between. Your video was also frozen. It's okay. Absolutely fine.
Uh,
Please resume back. Yeah.
this was the slide. One second. Okay, I'll present it.
Please get her slides. Kindly resume the slides.
Yes. This was the slide.
No, slideshow. Huh. Yeah, yeah. This was the slide.
Yes. Okay, sure.
You can just start
Shall
from
I
little
start?
because we lost you for 5 minutes almost. So please,
From nutrition workup, I'll start.
yeah, please, that will be better. Yeah, yeah. Thank you.
Okay. Thank you. Thank you. And we were working on nutrition workup to understand what type of nutrition should be given, what should be the strength of the nutrition, the route of nutrition, duration, feed adequacy, tolerance, etc. Because even if it is parental, sometimes intolerance would occur to that. And duration of parental as well as partial, either total parental or partial parental, refeeding syndrome, then transiting to enteral, when, what, how we are going to transit, and corrections of micronutrients was also a challenge. Then we worked on the drug compatibility with parental and enteral. Then post discharge from surgical unit, we continued in the medical ward for nutrition and monitoring. So post surgery, the patient was kept for nutrition and monitoring till he transited to oral diet. So, starting from the pre op initially, what was the nutrition intervention we planned and how we transited the patient over a period of almost like 40 days. Patient was with us for a long term because nutrition we couldn't do it overnight. We needed longer time. One, because of the risk of refeeding. The other, setting up or the abdominal condition getting better for nutrition and monitoring. So starting as Dr. Rajesh also mentioned, we couldn't continue him with the oral nutrition because planning for the surgery was one of the thing. So before posting for surgery, pre-op parental nutrition partially we started giving. So around 50 to 60% of the RDI we started, and around 1,400 calories with 80 gram proteins and 60 gram intralipids small lipid was used, and 2 to 2.5 liters of fluid was maintained. Apart from the parenteral fluid, IV fluids were also given.
If there were any more questions for Dr. Santosh, Rajesh, sorry, can we take that in the meanwhile? Or
Can we have Dr. Rajesh and we'll finish his one more question was there? Meanwhile, yes,
I
doctor. There
think
was
there
one.
is a Yeah, there are two questions, I think. Yeah, what about the gut microbe that could aid the healing process,
Yeah.
right? So the gut microbes will be severely affected because of the inflammation of the gut as well as the omentum, because the omentum is in close associated with the gut. I mean, it is lying just it will be lying with just superficial. When the omentum is inflammation, definitely the part of the gut will also be inflamed, and the gut microbe will definitely affected when the inflamed condition, whether it could be any gut microbe which is aiding for healing, or it could be aiding for the nutrition. So all the gut microbes will be definitely affected. Severe function of the gut microbes will be severely hampered. So that was one question. Answer for the question. Second one is there a significant weight loss or yes, in the chronic case there will be significant of weight loss because the absorption pattern is severely affected, as well as patient will be having loss of appetite. So both together can be detrimental, and the patient will be severely affected when it comes to the weight gain.
Okay.
I think those are the only two questions, ma'am. Yeah. Any other questions?
Any other
How
question?
long do you, sorry, how
Yeah,
long do
yeah,
you
ma'am.
think recovery takes, doctor?
Ma'am, depends upon the severity of the case. If a patient is under having a peritonitis as well as abdominal resection, it's going to take a long time, because healing of the gut itself will take a long time. Plus absorption and everything, it's a pretty longer process. In the case which we discussed, he was discussed after a week, following which was the recovery phase. The nutritional recovery and gain of everything is going to take a longer time, depending upon how he takes the food. So there's no hard and fast rule. Two things: one is the surgical recovery, the recovery for
Yeah.
entire thing. Surgical recovery,
Yeah.
depending upon the how bad is that, the recovery is going to take place.
Sure. Okay. Most of the symptoms seem like, nausea, vomiting, constipation. Is, is,
No.
is obstruction the only thing that differentiates, or is there anything else that we as dietitians also can look for?
But there are a lot of differential diagnosis. So there's no clear-cut diagnosis for this particular kind of syndrome, because first thing, it's a rare. Second thing, it's that it's been there for quite some times, and the patient usually presents to the hospital when it is a complicated, like
Mm.
abdominal
Yeah.
mass, severe abdominal pain, perforation, peritonitis, right?
Yes.
So
Yes.
identification exactly will be really difficult. Many a times it will be missed by many clinicians. Only thing is that
Yes.
suspicion as well as the CT picture will give a clear
CT.
cut idea. CT
Correct.
abdomen. Even with the
Oh,
X-ray as well as the ultrasound might
yeah.
not give you an exact picture. CT is the most preferred one. Gold standard is laparoscopy, or enter the abdomen and see. That is laparotomy.
Okay.
Yeah.
And you spoke about enteral and parenteral, so there is a clear demarcation, no, doctor?
Yes, yes, there's a clear demarcation depending upon the
Yeah.
bad. Like, if the
Yes.
patient is not that severe, then we could have tried with a slowly enteral. Otherwise, stop it. As Shobha ma'am was just now discussing, like to start with a little bit of parenteral, then make a patient stable, then do on further treatment.
Yeah. Okay. Thank you, doctor.
Thank you, ma'am. Thank you.
Dr. Shobha, are you set?
Yeah. Yeah.
Okay.
Please resume. Dr. Shobha, kindly resume.
Frozen again.
Sorry, I changed the place.
Still lagging, ma'am. Yeah, sorry about this, viewers.
Rejoining. She's joining from another system. Looks like some. We can just ask few more insights from doctor. Meanwhile,
You can ask, sorry?
we can ask doctor also to share some more insights uh, to
Yeah.
keep it little interactive, right? Instead of Dr. Rajesh, can we
Doctor,
have?
any, I think he's just got.
Yeah, ma'am, I'm here. Yeah, tell me.
Yeah, I think
Anything
there's
else that
some
you would like
network
to
issue
share?
with Dr. Shobha,
Yeah,
so you can just
uh,
share some more insight for our viewers. Most of our viewers are dietitians, so some
okay.
nutrition related insights if you can just share.
Uh, any other questions, ma'am? Like it would be best if I speak about the same case, or else any other cases we can have a discussion with respect to
What
nutrition,
was your
especially
experience?
critical care.
What was your
Yeah, ma'am.
experience with a dietitian with this case, doctor?
Experience with?
With the dietary team,
Okay.
how did you all work with?
Uh,
We have one question, I think.
yeah.
What is the threshold for implementing PN in patients with obstructive syndrome symptoms? Is this new question?
Uh, yeah, that was the question they are sent.
Yeah,
Can you
this
please
is what.
little
Yeah.
elaborate the threshold of implementing this? Like when are we going to implement? Like what exactly
Yes.
the
When would you
threshold?
start PN, doctor?
Okay, fine. The parental nutrition usually preferred when we are very sure that the absorption part of the gut is hampered severely, and whatever we are going to give uh, via RT or enteral feeds is not going to get absorbed. That is the first thing we are going to start a patient on a parental nutrition. Now, how do we confirm that? We confirm that based on the patient severity. Second, the CT abdomen findings. So these two are the factors based on which we will decide how early or how early we're going to start the parental nutrition. An early
Yeah.
parental
So these were
nutrition
some
means
questions that I had for Dr. Shobha. If you can throw some light on this.
an early parental nutrition should be prioritized
In
elementary
early
system.
enteral nutrition, should we prioritize elemental, semi-elemental, standard polymeric formulas, considering that there is a risk of post-operative ileus and potential mortality?
Uh, Considering poor risk of post-operative. Post-operative iliac part and potential mortality, yes, we can consider, parental for quite some times, prioritizing until and unless we have established, gut motility post-operatively. Because as I said, post-operative is going to take certain time for having a fully functional gut, so we can prioritize the parental feeds before going for a full enteral nutrition.
The next one, doctor, this is, to what extent would you recommend dietary modification of low fiber, low residue uh, to reduce the stress on the bowel and further prevent adhesive complications?
Uh,
How long would you restrict low fiber, low residue diets?
Restrict low fiber and low residue diet on in such scenarios, ma'am.
After the post-operative, in the post-operative condition, for how long
Uh-huh.
would we keep them on low residue, low fat diets? When can we slowly transition them back?
Ma'am, that depends upon the the what do you call that, the recovery of the patient. Again, the low residue diet and fiber diet we can restrict based on the appearance of the gut motility, and especially in this patient when the patient is has undergone resection and anastomosis. It depends upon which part of the gut has been resected and anastomosis. So usually what we do is, in such patients who has undergone a resection and anastomosis, either in case of the abdominal cocoon syndrome or some other infarcted bowel, we usually stop them or won't feed them until unless we are sure of two things. One is the good gut motility, and second is 4 to 5 days of post-operative. Make sure there is no leak in the gut and abdomen is soft without guarding and rigidity post-operatively. If
Oh,
these two factors are very much clear, then we will slowly start on adding on feeds,
fibers. Okay,
either fibers or extra things.
okay. Given the potential for for
Status and disturbance.
induced SIBO, induced macro bacterial overgrowth within segments of the encapsulated bowel, what is the best approach to screen for? And supplementation of
Screen.
fat soluble vitamins and B12.
Uh, Ma'am, I think this Shobha would be the better person to answer this
Yes.
question. So I wouldn't like, I can, but when we have an expert, I would leave this question to
I think
Shobha ma'am
luckily
to
it
answer.
looks like a better network now. So, yeah, welcome back, Dr. Shobha. Let's resume our slides. Would you like to answer this question first, or you resume the presentation first? Dr. Shobha?
Yeah, sorry, it was
No worries.
unmuted. Okay, I'll take up the questions at the end. I'll complete the presentation and take
Yeah.
up the questions at the end. Okay, fine. This was the slide. Yes. Okay. So we sorry for a lot of interruptions because
No
network
worries,
issues.
no
Huh?
worries.
My
It happens. We
apologies.
all face that often. It's okay, doctor. It's fine. Please
Okay,
continue.
fine. Uh, Thank you. And pre-operatively, I was speaking about parental nutrition because we had ruled out oral and enteral nutrition. So we started pre-operatively parental because we wanted to give gut rest also. We want the doctors wanted to understand how much of the abdomen has been affected, how much of fibroid is there. So total rest, gut rest. So we started with partial parental because risk of refeeding syndrome was one of the problem. The other is micronutrient deficiencies. So initially we started with 50 to 60% of the recommended intake. The patient required more than 2000 calories based on his weight and height. We started partially around 50 to 60%, and most of it what went as parental was customized parental nutrition. We did not buy the standard bags and hangover. We used customized parental at the bedside, and the nurses were trained. Okay, we did not use a laminar floor or something. Most of this case, we used a bedside customizing of the parental, and it was sterilely done also. So we used individual components of dextrose, amino acids, as well as small lipids. Along with that, the compatible micronutrients and trace elements and vitamins were added. And administration was initially we started with 20 ml for the first 15 minutes and slowly increased it to 30 ml per hour, and we scaled it up to 50 ml per hour over 4 to 5 hours. And patient was closely monitored so that no cardiac event should occur, because patient is a known case of cardiac. And other thing was we had not consumed adequately over a period of time. So close monitoring of blood sugars, electrolytes, and signs and compatibility to parenteral and risk of repeating. We monitored these closely using the blood parameters, electrolytes, and other signs and symptoms. So the parenteral was increased, the strength and volume was increased to 1600 calories with 90 gram protein and 60 gram lipid and to 2.2 liters of fluid. Fluid not just from the parenteral, even the IV fluids along with medications which were used for dilution also continued. So continued with the partial parenteral nutrition at the same rate of administration, and strength over the next 4 to 5 days. We continue with the same parental nutrition volume and strength for next 4 days, and including post-op day 1 and day 0 and 1. Then the volume and strength was increased. There was no stopping of parenteral intra-op also. Intra-op also we continued the parenteral part at 1600 calories, and around 1.8 liters fluid was used for this volume. So the volume and strength was increased gradually over the next 5 days, and we were able to achieve full volume and strength by day 11 post-op. The patient was discharged from the surgery unit, and we continued the patient in the medical ward for parenteral and to transit to the oral diet. So post-op by day 11, we were able to achieve 2100 calories and 100 gram protein and 70 gram lipid. We were desperate to increase the protein because of the total proteins were very low in the serum, as well as albumin was little low, and we wanted the surgical wound to heal faster, the anastomosis also to heal faster, and patient recovery we wanted it better and better tolerance to the surgical insult. So that way we were desperate to bring it to 100 grams, and around 294 grams of dextrose was given to meet up this calorie apart from the lipids as well as proteins. So the compatible vitamins, minerals, and trace elements were also added to the TPN, like I've mentioned. But here what we shifted was, instead of potassium phosphate, post refeeding window period, we shifted it to potassium chloride. That was the only change we did. Rest other nutrients were same, and administration was achieved at 120 ml per hour for parenteral, around 18 to 20 hours, and in between we were giving a break of 10 minutes for medications. The lines were flushed and medication was infused, then again reflushed, and a break of 5 minutes was given, 5 to 10 minutes roughly around, and then reconnected back with the parenteral. So no medicine was added to the parenteral, and we did not give iron dextran or iron supplement during this entire treatment, though patient had mild anemia. Nowhere we added any of the iron supplements during the treatment. So day 12, we were able to start with minimal enteric feed, but we did not rush through. It was a trial, and around 10 to 20 ml roughly we were able to achieve. Every 4th hour clear liquids were given, and tender coconut water, as usually we started it because it's one of the clearest and the purest thing. And strained watermelon juice and muskmelon were used. And apart from that, free fluids were given for the next 2 days also. So once the free fluids were started, slowly IV fluids were tapered, and no aggressive feeding was done because we wanted to avoid any gastric stimulation or gastric secretion. We wanted the surgical wound to be healed properly and no other complication arising from the gut. So day 15, by day 15, we were able to start full-fledged clear liquids of 50 ml and introducing other foods also. Like dal water, soups were also started for this patient. So every 3rd hour we were giving around 78 feeds, and the next day we transited to 75 ml. So we continued this for the next 3 days along with the parenteral support. So by this time the entire IV fluids were tapered off, and most of the medications were also tapered off. So PN was continuing at 70 ml because we started enteral feed, so we reduced the PN volume to 70 ml per hour, and we continued with the same concentration, but we did not change the concentration, but continued with the 70 ml over the period. And this we could maintain till day 3, when day 23, when we achieved full strength enteral support. So we could transit the patient from the clear liquids to enteral formula. We started with an elemental formula feed. Alternate to the clear fluid, we started with peptamin, 2 scoops. The concern was of the higher osmolarity with the elemental formulas. So we just kept it little lower side, so that we don't change the osmolarity or cause gut obstruction, gut intolerances. So we just wanted to keep it around that. So we just started with a smaller volumes, and then once we were able to stabilize and feed tolerance was good enough, then we shifted to full strength of peptamin, and this was given as a continuous feed. We used a bag, feeding bag, and continuous feed was given. But in between, we were giving breaks, feed breaks of 15 to 30 minutes for gut rest and medications to be administered. Only one medication was given over, the rest were shifted to the IV lines. And patients transited to sip feeds, oral sip feeds liquids, and then to semi-solids. We shifted from the kitchen feeds to the peptamin because we wanted to feed it continuously and see whether tolerance would be good and patient gut recovery would be good, and we wanted to also check whether the gastric stimulation and enzyme would be compatible with it. So once we started on the elemental formula, we closed with the kitchen feeds. Only elemental formula of parental was continued for the longer duration. Then once patient was tolerating, he had smaller stools and better compatibility with the feeds. Then we started with sips of oral liquids, and this was clear liquids initially, and then slowly we transited to semi-solids. Then feed tolerance was good and intake became evident. By day 40, in this patient, we were able to achieve adequate intake orally. But we never gave him solids because the surgical team said not to start any solids because they had some more concerns with him. Because of the fibrosis condition, they wanted to wait for some time. So continuing almost like 2 months, we continued. Even post discharge, this patient continued on liquids and semi-solids, and foods which could demand gastric stimulation or secretion were restricted, especially the spices, condiments, high fiber foods, and only soluble fiber was given, or the soluble fiber like mucin, pectins, and gums were allowed. Rest of the fibers were reduced, and even the gut microbiotic foods were also reduced in this case because appendectomy was one. The other thing, the syndrome could come back, some other problem could rise up karke. So we wanted to avoid inflammation also in this case. So we reduced giving any of these curd, buttermilk, or milk products for him. And on the a patient was discharged around 40 days, and we requested him to come back in the OPD. Advised fortnightly was supposed to come back, and he was supposed to maintain a diet dairy, which he did for longer duration. Almost for 2 years he was maintaining the diet dairy, and we monitored him for a period of almost like 1.5 years. So once his recovery was better and he tolerated, so he was transited to normal diet. It took a little longer time. It took almost like 5 months post discharge to shift to normal diet. But even in that case, also we did not advise him of spices or condiments or masalas, which could increase his gastric demand and circulation, or which could trigger other complications. That was the concern we had. Apart from that, rest of the foods he tolerated, and he was doing better when last I was able to see him. So no oral supplements were given except peptamin, and it was advised as a reconstituted sip feeding, 6 scoops into 250 ml to 300 ml of water twice a day for a period of 2 months. But he continued taking it for 5 months. This we ensured that because he had fears of taking food. He thought food, if I take food, I would get more abdomen pain or discomfort, indigestion problem. And because he also underwent appendectomy, he had a concern like whether I should eat hard foods or not, or normal food. So he himself continued, though we had advised for a period of 2 months so that we maintain adequate nutrition and whatever nutrition losses he had, weight problems here, that could be corrected. So we were able to achieve a good nutrition status for this person over a period of 5 months, stabilized. And he, when last I had met him, he was around 69 kilos. All his blood parameters was fine, and surgical wound was good, and he has tolerated, and he started living much better. So coming to the discussion point, weight loss is common in these conditions. Even malnutrition is common, and this occurs usually because of recurrent abdominal discomfort, then tenderness of the abdomen, nausea, sometimes vomiting, also intestinal distension, abdominal masses present. In all these conditions, you get to see the intake of food being reduced, and interest in eating also was reduced in this person. So even with no signs of nausea and vomiting, also many patients reduce their intake because of the discomfort and they lose interest in eating foods. So in case of this patient with abdomen cocoon, digestion and absorption of nutrients also was reduced to a larger extent. And nutritionally, elemental formula would be best when you shift to enteral so that digestion would be easy and extra gastric demand would be reduced, and more on the better absorption also, and quick nutrition recovery can be seen in this condition. But only concern with the elemental formula is osmolarity. So maintaining the osmolarity value somewhere around 300 milliosmoles per liter of or per serving of the formula would be really good. So initially parenteral is ideal, and pre and post op nutrition management, especially using parenteral, and if it is customized to the patient clinical condition, the tolerance and recovery would be much faster. But in these conditions where you see abdominal cocoons, long-term management becomes a key for success and maintenance of health. Thank you.
Thank you, Dr. Shobha.
Thank you.
Thank you, Dr. Shobha. There are questions waiting for you now. So we'll start with some, ma'am.
Please
This
get
one
doctor
was,
also.
sorry?
No, no, I'm just asking for doctor also, Dr. Rajesh also too.
Yeah. This one, doctor, given the potential for stasis, can you see it in your comments?
Yes.
Yeah. What is the best approach to screen for and supplementing of fat soluble vitamins and B12?
Fat soluble vitamins initially we don't give, but slowly we start. If it is on the parental line, definitely we give them. But when it comes to oral, we little hesitant about giving that. But most of the abdomen cocoon cases or abdominal surgical cases, we always go into the parental corrections. But parental intraliquid is one of the source of bacterial thing, and infections related to parental nutrition are always with the fats, lipids. So, how much you give, what you give through that becomes one of the challenging aspects which I have noted. But in this case, we gave total, we were able to achieve total parity, but we gave lipids also and the multivitamins also. Fat soluble, it's a multivitamin with both fat as well as water soluble vitamins. Fat soluble vitamins were not much of the deficiencies which we noted. What we noted was vitamin D, of course, it was one of the concern, and related to calcium also, and water soluble vitamin K related issues were more for us.
Okay. Yeah. Yeah, it makes. I understand. Do you
Next,
routinely use rehabilitation nutrition protocols?
yes, we
Like,
do use. We do use prehab nutrition also, and post surgery also we do continue nutrition also. High protein definitely, immunonutrition only if it is required and if it is immune compromised or age related concerns, or somewhere if it is onco related, definitely we use. Otherwise, we don't go.
okay. What is your approach in severely pathetic patients? Sorry.
So, in case of TPN, always be cautious about refeeding and micronutrient deficiency when you start with cachectic patient. Don't rush through giving dextrose, I mean to say the carbohydrate load, because that could induce the refeeding syndrome. That is one. And most important, start always with 50% of the RDA or your RDI, your recommended allowance to recommended intake. 50% you start with and slowly build it up. So you get a picture like how patient can tolerate, especially when it comes to parental nutrition. If dietitians are well trained for parental, they can customize, they can manage the osmolality of the parental solution. They know how to run on which line, what should be the weight, volume, and the density of the parental composition, which medications are going, how they are compatible. If they are well knowledge in that, definitely they can start. And if there are concerns, adequate skill issues, then please don't work too much with the parental unless you learn, is what my advice. So most of the consultants also don't work much on the parental. They usually use the standard bags and go slow with the patient so that no complications should arise with related to parental. Long duration parental will be one of the concern, because parental induced liver failure is another risk we always see with long duration parental. And triglycerides going up is one other concern with the parental part of it. And if you are infusing too much of dextrose, if it crosses 7 grams per kg body weight, even blood sugars will go up. So always maintain somewhere between 5 grams to 6 grams. 5 grams is usually what we look at in case of parental, but in this case we used up to 7 grams, and we also added little bit of atropine to this also to manage the blood sugar so that it should not be an insulin issue. Correct. But starting in cachectic patients, I usually ask them to go 30% and then shift to 50% slowly. Build up nutrition slowly. Don't rush through the patients. Long-term management concerns was one, keeping the patient long on parental was one of the concerns. Second thing is, once the patient recovered and he felt he start, the urgency to eat normal food was noted in this patient, because they would have missed eating normal foods, normal tasty things. The taste was one of the concern, palatability. Almost like 1.5, 2 years he had not eaten adequately, and for the past 7, 8 months he had missed out so many foods in the food groups. He was only surviving on some dal water and some curd rice or buttermilk rice, something like that. So he was so desperate to eat a normal meal. We could see that, like it was literally begging, when can I start eating my roti or dal or pakoda and all. So it was like I myself was going into that psychosis, understanding the state of the patient. I myself was desperate to tell, yeah, you can eat, but again holding back. I was telling, no, you can't afford to increase your gut secretions or stimulate your gut. You have to wait, not just the surgical healing. We don't want it to recurrent, come back to you again. So that was our concern. Even the surgeon said, don't put him into normal diet. We want you to wait for some more time. So the day when he came on the last meeting, when after the 5th month, when we said, yes, you can go ahead, start normal diet slowly, and he said, can I eat something today? So we offered him, actually one of the resident doctor in the ICU bought him a masala dosa and gave him. You would have seen the emotional pain which he had when he consumed it. So he was literally almost like half an hour it took us to bring him back to sterilize it. Almost all of us were in tears when we saw him eating that. And his family also. He had 2 daughters, teenage daughters. So when they saw him eating a normal masala dosa, they thought like, okay, this is the best day of our life. It was like that for him. But we still
Yeah.
advise you continue little bit slightly on the bland side. So once in a while keep cheating, and slowly once you are stable and the surgery team said yes you can go ahead, then definitely you can shift.
True.
That
Yeah.
was one of the most challenging situation for us when it comes to long-term management and a bland diet, keeping patient on liquids for long. This happens not only in this abdominal cooking, even onco patients also we get to see this problem on and off.
Mm. Yes. So I thought of this, since we have a doctor also here. What support or information would we need as dietitians from treating doctors for better planning of MNT? Additional, you get a
Basic.
lot, you have a
Yes, of
lot, but
course. Yeah. Always what I do, I'll tell you in my settings. I always discuss the case with our doctors. It's an open discussion also. We
mhm.
always exchange information. We try to synchronize that both of us are on the same line. and we try to work upon the nutrition parameters so that nutrition mediated complications should be minimized, and nutrition mediated as well as drug nutrient interactions, all this should be minimized, and we try to shift the patient to the normal diet as early as possible. Of course, there are conditions where it doesn't work out. Clashes have been very minimum. I'm sure whichever teams I have worked in the last 10 years, though many of them tell Shobha ma'am, whatever you decide, we are okay with it. But when it comes to discussion, no, always doctors help us. When it comes to the labs, which one do the best for the patients, and we always discuss. Like if I want to check if there is, I wanted to check whether fat was observed adequately in this patient once he started the normal diet when we shifted to. So I was worried if fat absorption is not adequate, he might have fat in the stools. So we asked for a fat analysis in the stools. So they readily agreed for it. So there are, if it is clinically and technically agreeable, definitely they will agree. But I request dietitians not to take it as a fancy thing to go and get every test done. You should relate it to the clinical condition. Definitely, majorly all of us are doing that.
Yeah.
So the treating doctors always see that the more you sound more clinical and more, what do you say, authenticating your treatment or intervention, and bridging that gap between the medical treatment and nutrition is very important for all of us. So you have to discuss and see what they are looking at and what you can cater, and how safely you play with the nutrition with their patient, because they put in so much of efforts getting the patient to stabilizing or even surgically intervening or seeing that the patient recovers. Small bit of error in nutrition can complicate majorly, at many times it happens.
Yeah.
So
True.
nobody wants to complicate their patients. So always go with them, take your rounds. This is my advice to all the practicing dietitians. Discuss with them. If you are not skilled enough, reach out to people. We are all, so many of us are available, and thankful to the team which has come up with this interesting episodes of case studies, because this gives you an exposure also. So you should always take your clinical side, because nutrition is no more food science, or it is not like what you eat. It is like what you intervene. It is a therapy now. So the coming years, no, most dietitians will be getting into intervention therapy. So your medical knowledge is priority here, not just nutrition knowledge, it is medical knowledge, which is very priority, and build up your skills, and always be a part of this multidisciplinary team. Don't isolate yourself. Be part of the multidisciplinary team. Then you will learn a lot and you will achieve a lot also.
True. Next question, please.
I think that's all. Okay. What support? Uh, what support or information? Okay, from the treating doctors, we've got that. I think we've done it.
Any
Can
vitamin supplements used?
peptide-based semi-elemental formulas be used in patients with ileostomy or acute severe pancreatitis? So different forum, but if you all
Yeah.
can answer.
The vitamin, I think there is a question popping up. Any vitamin supplements used during parenting? Yes, we use vitamin. That
Yeah.
was used online. I mean, I'm IV lines only, which was added to the parenteral solution. But once we shifted fully to the enteral formula, we stopped giving parental and parental related vitamin supplements also, because peptamen was adequate enough to meet up major most of the nutrients. So we did not supplement, because we had given adequate amount over the period of time through parental. So we did not continue on that. And multivitamin injection was definitely given, which comprised of both water soluble and fat soluble vitamins.
So can peptide-based semi-elemental formulas be used in patients with ileostomy or acute severe pancreatitis?
Yes, you can use maybe for a short duration, and then you can transit to full-fledged polymeric formulas. That would be ideal. Ileostomy, initially we start in acute severe pancreatitis if they have vomiting, nausea, and other problem, abdomen pain, वगैरह. You can start with sips of elemental formulas or semi-elemental also. In case of pancreatitis, the enzymes required for digestion, majorly most of your 90% of enzymes comes from the pancreas. So if severe pancreatitis is there, then you shift slowly from. I usually go with elemental formula. I don't go with semi-elemental formula for these cases. So then I shift to normal diet or whichever is feasible as per the patient condition. There is no fixed diet criteria. Every patient is different. So we shift to patient per se. The nutrition varies for me. I don't have a fixed diet, but general guidelines apply here. That's it, what I would like to say.
What is
Lots
your
of
take
questions
on
are there.
introducing probiotics? Yeah, lots are coming up.
Probiotics, we waited for some time. Like I mentioned, curd, buttermilk, or fermented foods were not given for consumption because we had a query. Even the surgeons had a query: don't introduce any probiotic because patient may or he may develop gastritis problem or bloating, flatulence problem because that was one, and the infections can also be one. He may not tolerate any of the probiotic was the concern. But I did not work much with that, and slowly we went on to shift him. After 3 months, we shifted him to curd and buttermilk, but it took little time for us. And the patient himself psychologically was refusing to take curd and buttermilk because he was on that and he had developed a aversion to curds and buttermilk. So probiotic foods at least post surgery, any of the gut surgeries, no, wait for at least 15 days. Don't rush to give that because the gut would have been sterilized for the surgery. So when you introduce any of the microbiotic foods into the diet of the patients, no, there can be some amount of inflammation occurring or infection. So wait for some time. After 15 days, you can definitely slowly introduce it.
Yeah. Dr. Rajesh, again, there's a question for you. What is your approach in severely cachetic patients? TPN first or early surgery?
So muted, I think, sir, you're muted.
Your Dr. Rajesh, you're on mute, it
I got
seems. Kindly unmute yourself.
got it. Got it. Okay. Yeah. So yeah, as I said, early surgery versus TPN first, it depends. If the patient is landing up with an emergency scenario, then there's no option of waiting. You immediately take the patient for surgery. But yes, if the patient is has come into the department with no emergency complication, we still have some time. Then again, depending upon how cachetic the patient is. If the patient is too cachetic, then we immediately ask for a TPN. But if surgery is mandatory, as early as possible, we go take the patient into the surgical department. Depends on the case by cases. Patient with peritonitis or peripheral rupture, comes priority. After that, we start on PPN. Then slowly, when the gut improves, then start the patient on enteral feeds.
Yeah. So, do you routinely use rehabilitation nutrition protocols? Oh, we've done that. Sorry, sorry. We've gone back.
Is this repeat question?
Yeah, it's a repeat.
Can we have the next question, please?
It's no next.
I think it is all done.
It's over. Yeah, we've done
It's
it.
over. Very interactive. I think audience also asked a lot of questions. So
Yeah. Can we go?
would you like to emphasize on any particular situation or incidents while treating the patient that you both have would like to emphasize on other than these questions?
Dr. Rajesh and I worked almost 6.5 years in intensive care units managing neonates, pediatrics, adults with cloud physician, and we used to have diverse cases across India and offshores also. So I don't know how many thousands of patients we have seen in the ICUs, only ICU management. Right? The one case which I remember was like one of the doctor had started an adult patient on keto diet for epilepsy. So this was an external case, and patient came with seizure to our ICU, and one more other doctor also, Dr. Sanu was there. So he said like we were little bit not in pro for keto diet for epilepsy. So we usually say no, no, wait, we will wait. We don't advise keto diets actually, especially in pediatric population. We just go a bit little different. So when we got, and the ground doctor was insisting nahi keto diet karna hai. Keto diet is required for the patient. We don't want any other diet. So the doctor as well as the ground dietitian were very much keen to continue with the keto diet, and our team of doctors were not ready for it. So first 2 days we left it because we were seeing a lot of ketones present, and nothing was working. And they were giving whatever they were giving, the patient was developing low stools. Almost 8 to 10 episodes of low stools were seen in a day. So day three, I think almost like 12 to 13 episodes were there, and patient was not recovering. So one of our doctor, I think Dr. Sanu was the one who took, and Dr. Dilip also got involved. He said like, we don't want to handle this patient because you are not listening to our dietitian. So our dietitian is not pro for your keto diet because it's not helping. So it was always MCT diets, giving a lot of coconut oil, all that was going on with the patient. So they dropped that patient. After 2 days, they came back when patient became severely dehydrated, everything. Then we started working on this case. They handed over the full responsibility, and we requested that no dietitian or doctor is going to get involved. We have our specialists, they will look into it. So we started it. Within 48 hours, we were able to bring patient back to near normalcy with whatever little change we made for him. And day 4, 5, patient was stable, normal, sitting on the ICU bed, talking to the neighbors on the next beds. So that was challenging because telling one specialist not to do what you are doing, and one they don't agree what is right for the patient, dropping it, saying no, we won't treat it. Karke. That support what I got from our doctors was really good. This is one example. Like this, we have got many examples and many cases which was done. Because keto diet was one fancy thing those days in the last 3, 4 years. Even now, I get to see some cases like that, but we don't work with that sort of a thing. We see per patient, I mean, patient per se, how it works. What is the current requirement of the patient? What is the need? Accordingly, we were supposed to manage the diet. So if somebody says, I'm not happy with what you are doing, and if you feel and confident that you are doing it right, your nutrition approach is right, be confident of that. Don't give up. So if they say don't do it, we are okay, just leave it. It's not an insult. It is their way of pursuing the case, and it is our way of pursuing our approach. So it's we get a lot of what do you say, professional egoism at times. So that
Yeah,
also happens. So that way we can
yeah,
definitely encounter. Fortunately, I have worked with most of the doctors who don't have that sort of thing.
yeah. But you've had good support so far, so
Yes.
that's nice. Yeah. So that's what I was coming to say, that this is, not about dietitians, not about doctors, but it's how we can win and how we can make the patient win too. So if we've all if we have all had our fill, this is our time to say thank you. Thank you to Dr. Rajesh for this, for taking time out first and sharing with us valuable insights, valuable information, and patiently explaining so much to us and answering so many questions. Thank you, Dr. Rajesh. Thank you very much.
Thank you, ma'am. Thanks a lot. Thank you.
Dr. Shobha, we thank you for your persistence and keeping your act together and coming back so many times and joining this session. Thank you for answering so many questions again. Thank you for your insight. We know there's a lot of knowledge there, and we are glad we could have a share of it. So, thank you once again. Thank you, Priyanka, for this
Thank you.
session, for hosting, and thank you, everybody, for logging in.
Thank you.
Thank
Thanks
you.
a lot.
Thank
Thank you,
you.
everyone.
Thank you.
Looking
Thanks a
forward
lot.
for
Thank
more
you.
sessions.